Today we're participating in the President's Symposium, which is usually held at the annual convention, where we deal with issues that are pertinent to our membership and issues that are affecting dentistry from state to state and also throughout the dental community. So that's what this forum is all about.
What are some of the big issues facing dentists in the United States?
Right now, the biggest issue probably is Medicaid access to care in terms of with the Affordable Care Act. We have a lot of changes that have been made by the states. Some of the states are participating and some are not, which is making it a little bit harder for us. The ones that are not participating, it's a challenge for us, and the ones that are, we have more patients in a lot of cases, especially some of the Medicaid patients, because the children, I think from maybe 0 to 19 are covered at a greater level than the adults. Of course, there's no coverage for adult patients, so that makes it difficult for us. And the other issue that's I would say that affects us as African American is the amount of African American students that are going into dentistry. That is going to cause us to have a shortage of dentistry in our communities.
We're seeing a decrease in the number of African American dentists. However, we at the National Dental Association are very committed to encouraging African Americans to pursue professions in oral health. It's an excellent opportunity and an excellent profession to pursue. Through the NDA, we reach out to students who are in high school, as well as students in college, and students who are actually in dental school. So we are reaching out to continuously encourage students to pursue professions in oral health care.
It's a concern because mostly the African American dentist is the one who treats a minority and underserved populations. So when there's a decrease in the population of the African American dentists, there's a decrease in the population of practitioners that treats that segment of the society and minorities and underrepresented people and people of color.
Well, to get more African American dental students or to get them interested in dentistry, we have to go out and actually do some mentoring one-on-one with them. A lot of the African American students are not even aware of the opportunities that are there for them to get into dental school, and a lot of them unfortunately come from disadvantaged backgrounds where they may not be able to afford dental school. So we have to make things available for them, scholarships, where we can recruit more and then actually, even more importantly, retain more students in the dental school profession.
I think the first thing that we have to do is start with the real young children by educating them in reference to dentistry is, to me, one of the best professions you can go into. And I read just maybe about 2 or 3 months ago where dentistry and dental hygiene is one of the top profession there is to go into. It's where we can make a difference and tell the kids about the goodness of it all and how they can change their lives as well as their family lives, as well as the community. They can have a positive impact on the community. And don't stress that you got to go to school 8 years, 4 years of college, 4 years of dental school. Stress the fact that those years will go by real fast, and that what were you doing 8 years ago? And most time they will probably say, well, you know, I really don't remember. It just went that fast, or I can't remember. Stress the fact that, you know, the time will go by fast, and money is not an issue. No one should ever not go to dental school because of money, because we will find money to get a kid that is young person that is qualified and have an interest and a passion. So we start real young, I think, is the key, to get them on board and track them. And our DID program is doing a lot of that right now, which I think is a great program.
Dentistry is a great profession. It's a great opportunity. I've been practicing for decades, and it's just been awesome. I appreciate the opportunity to interface with my patients, to provide patient education to them, as well as to provide their oral health care. So it's a great opportunity and a great profession.
I became a dentist because of the natural desire to want to help people and being concerned, and I knew that with dentistry, we could still help people with their health, but you're focusing on something that is most people don't see as important. And growing up, unfortunately, I was one of those kids that spent my time in the dental office, so I definitely decided I wanted to help people in that sense too. So
I think we really need to work at the level of high schools also, as well as undergraduate level, to introduce students in the sciences, to introduce them to dentistry as a profession, dental hygiene as a profession, also, and to let them know that there is a viable professional opportunity in becoming a dentist, especially since we know that African American dentists or dental school graduates are most likely going to set up practices in their communities as well as serve their communities. We know that from studies that student dentists, when they graduate, they do go back to work in their communities. So there are occupational opportunities.
What is the situation with Medicaid reimbursement for dentists?
Well, the biggest situation is the lower reimbursement rate. You know, dentistry, keeping your practice open is very, very expensive. It's not cheap at all to run a dental practice. It's a business as well. In comparing it to medicine, most dental practices have their own x-ray equipment. We do all of our processing there. We have our computers. Then we have our dental chairs and all of our dental equipment. We don't outsource for x-rays. So our overhead is very expensive, probably to the tune of 65% of what we make. So if Medicaid is reimbursing us at 20 or 25%, maximum 28% on the dollar, then that is not going to cut the expenses that we have, because we have a staff or a team of people that we have to take care of. And Lord forbid, our salary in itself is not, most time we don't make it from Medicaid.
That's one of the problems. So many of the doctors are leaving the inner city because of the low reimbursement. And we understand that the states allocate this and mandate this, so perhaps we need to go back and talk to the states again about this.
The doctors are basically performing the work, and we're not being reimbursed for the services that's been provided simply because there's a certain amount of monies that that the insurance companies that's running the state programs now that can pay us. And so because of that cap, so to speak, we're being left at bay of not being able to be reimbursed properly, or let's say, so to speak, enough that would be commensurate with the amount of work that we're doing on these children. And that's the whole issue, is trying to take care of the children that have to be turned away because of the change of the bureaucracy of how these kids now are being told I'm not a provider, that they have to go somewhere else to where that provider is, or the doctor that they're presented to have to change them at that moment, which takes a lot of time. And that access to care that they're trying to get to, it makes the parents and the patients to the point where they care not to access it because they're going through so much bureaucracy.
Oral health professionals really need to step out of the box and work collaboratively with other providers if they want to see the health conditions of the communities that they serve improve, as well as getting a better value for care and improving the experience of care for patients in their communities.
Tell us about the issue of access to care.
The issue of access to care to me is very personal. I have to tell the audience, the listening audience, that I am a byproduct of the Medicaid system. I was born with vitamin D deficiency, which is rickets. My mother had the tenacity enough to seek the doctor, the local dentist in the community, to find out why my baby teeth didn't grow. So she went to the local dentist, who was treating us at the time under what we call the welfare system of general relief. That doctor, through his education, his experience, referred us to a hospital of specialists. And that, because of that referral base, basically, my mother, through the support of the welfare system, was able to get me to a specialist who basically told me I had rickets, vitamin D deficiency. As a result of those rickets or vitamin D deficiency that I've outgrown, I've learned to come over the course of my last 63 years, I became a dentist because I was concerned about how that happened. So what happens now is I see young moms, we see young parents who come into the office, and we're doing what we call the first dental home to explain to them it's important that we start at age 1, at first birthday, so that we can make sure that we can guide them through a lifetime of good dental health, good dental repeat, or so to speak, recalls, so that they can prevent themselves from having issues like I had with their children, and especially when we're talking about today's society of the kids wanting so many of these sugar highs, or so to speak, the sugar candies and those, I don't want to mention names of the companies, but they're basically, kids are just eating too much sugar and so many snacks that's causing what we would consider early childhood cavities or early childhood caries and nursing baby bottle tooth decay. And that's something that we're trying to prevent by access to care and getting these parents, these young parents, just as my mom was at the time, into the office so that we can tell them from this day forward, this is what you need to do to prevent any unnecessary disease that would be a calamity to the child later on.
Access to health care is important, but access to oral health care is really important because oral health is so integral to good overall health. And if patients have access to oral health care, then we can be more assured that they'll be healthy overall.
Without good health, without good education, without all these important determinants of well-being of our population, we as a society will never improve. This is a very important part of the overall success and future of our population. So I think it's just very, very globally important.
My message is to the National Dental Association that we as legislators, we have a common interest, and that's providing access to oral health care for our constituencies on the state level. As being president of the National Blunt Caucus of State Legislators, this is an important issue to us, and we've passed resolutions all across the country supporting oral health, particularly fluoridation of water, and issues such as that. So today was important that we extend the hand of cooperation and working with the National Dental Association, learning from those dentists what's going on actually in their offices. And they've expressed to us today how they feel and where we're falling short on the local level, state level, and even on the federal level when it comes to oral health issues.
To do one of his outreach clinics here in the States, and particularly he did one in Knoxville, and to his surprise, that when he set up his remote area medical on the fairgrounds in Knoxville, Tennessee, and announced it, that over 2,500 people showed up. People showed up the night before, standing in line when they heard that they could receive, that adults could receive free dental. So that shows you the need out there for not only children but adult dental care. And but the truth be told, we shouldn't rely solely on the generosity of you as professionals and the generosity of churches and community centers. We as elected officials have to find a way to pay for and fill these gaps. It's incumbent. Thank you. And is it incumbent upon us in Washington, in the state capitol, and city halls, and across the country to play our part in promoting a strong healthcare system? And as a lawmaker, I understand that public policy decisions that come before the legislature can make a difference in people's lives, and it makes where people can or able to receive affordable and quality and reliable health care. And all this is including oral health care. We know that health care and their costs are some of the most important issues that are facing us as legislators. I served previously as the chair of the House Health Committee. So I've been on the front lines. I've been in the back rooms. I've been in the meetings before the meetings about decisions that affect how health outcomes and how decisions are being made. But on both the federal and state level, I realized that in Tennessee too, we spent tremendous amount of public dollars and resources on managed care. But these resources are rarely ever matched with the results that we're getting in the community. In fact, what we see more often than not are organizations such as yours that do the due diligence, learn how to operate within the system of government, and then all of a sudden government makes a habit of switching the rules of the game, around and forcing healthcare providers like you to scramble for new ways to provide jobs and opportunity and make a living. And we have to do something about that. I've seen this trend take place in physical and mental health, and now that trend is taking place in oral health with the MCOs, the HMOs, the PPOs, the MOUSCs, or whatever you want to call them. You know, we see this change going on. You know, Tennessee is a battlefront, and just lately issue has come to Tennessee. In Tennessee, our Medicaid program is called TennCare. And in 1994, we took the entire Medicaid population and placed them in managed care. That was $3 billion in 94 dollars, $3 billion that was transferred from public coffers to private coffers. It was the largest transfer of public funds to private entity in the history of our state. And with that program, you know, in TennCare this year, or last year, a new contract was awarded to an out-of-state provider who sought to cut costs, you know, to cut costs. And with that, a lot of our providers of color were left out of those networks. We're still working, we're still fighting to provide a fix of this issue in our state and try to maintain care and make sure that our providers are treated fairly. And this organization was is a part of the solution that we're making progress in Tennessee. And certainly at the end of the day, I hope essentially that healthcare providers all across the country and even in Tennessee, that they reflect the population that they serve. So if you have a large population of African Americans in your TennCare and Medicaid programs, certainly the provider network should also reflect those providers of color. I've been given the word that it's time to sit down. I think in the discussion, as we have more, I wanted to get to talking about being an advocate is very important. There are a number of, you don't have to be an elected official, but there's a number of boards and commissions that you as professionals can be a part of. I encourage you to seek membership on those boards that make regulations, that make rules, because there's an old saying, and it's been said at this conference before previously, if you're not sitting at the table, you're on the menu. And the only way, we have to be a part of these commissions and boards and be a part of it. And you as practitioners, providers, also with your patients, you have to advocate to your patients to make sure that they're good consumers, to make sure that when they come in the office and you do your patient surveys and questionnaires, don't be scared to ask a political question or you register to vote. Have a voter registration ballot in your office and give to your patients, because that can be one of the most powerful tools that you can have, is that patient standing up speaking for you. And so you have to mind that particular population that you serve.
The message is talking about how about 47 million people who live in dentist shortage areas and 15 million kids who are on Medicaid who didn't go see the dentist last year. How can these people get access to dental care? And what we're talking about today is how dentists can use mid-level dental providers to expand access. They're less expensive to employ, and we're finding that dentists who employ them can serve more Medicaid patients and turn a profit. So I'm going to be presenting findings on this research.
Let's look at another trend in economic conditions for dentists. Annual income. This chart shows that since about 2005, income has declined significantly. And exacerbating that decline is heavy debt that dental school graduates are burdened with. So in 2013, our studies show that the average amount of debt that a dental school graduate leaves with is over $215,000. Well, let's now talk about this other chronic problem, which is access to care. For decades, we know that millions of Americans, mostly low income, have been receiving inadequate care in our nation's delivery system. The Institute of Medicine calls our delivery system broken. So there are a number of factors that are making it hard for people to get care. We were just talking about the lack of dental insurance. That's one. There's also a maldistribution of dentists across the country, which is leading to a lot of dental shortages in many areas. And finally, this is very important for low-income people, few dentists accept Medicaid. So that's a problem. Now let's do just a brief dive on these numbers, and then we'll talk about promising workforce models. Right now, we've got about 47, this is according to the federal government, we've got about 47 million Americans that are living in an area of the country where there are a shortage of dentists. And so even if they do have dental insurance, it makes it hard to get dental care. Again, according to the feds, we need about 6,000 dentists to care for patients in these areas. Let's take a look at who accepts Medicaid. There's a national organization, the Medicaid Medicaid and CHIP State Directors Association. It's dental directors and Medicaid and CHIP. They did a survey in 2012, and they found that on average, less than 30% of working dentists filed more than 50 Medicaid claims. 33 states participated in the survey. So you all are acutely aware of the many reasons that dentists don't accept Medicaid. There are low reimbursement rates, there's burdensome paperwork, there are high rates of missed appointments among patients. But what happens partially as a result of this is that there are a lot of kids on Medicaid that aren't seeing a dentist. So in 2012, we found, or according to the federal CMS, more than half of children enrolled in Medicaid didn't receive any dental care at all. It's very much worth noting that African-American dentists, and this was mentioned in the previous in Jillian's presentation with different data, but African-American dentists are much more likely to treat Medicaid patients than other dentists. There's a survey that found that, a survey of dental school graduates that found that 43% of Black graduates said that serving low-income patients was key to why they wanted to pursue dentistry, and only 23% of all other graduates answered the same. Well, at the end of the day, the fallout from a dental care access problem is seen in ERs around the country. The ER treatment for these patients is often a prescription for antibiotics and painkillers and an instructions to follow up with a dentist. We all know care in ERs is inadequate, it's expensive, and it's largely unnecessary. There was a recent national study that looked at care in ERs for preventable dental conditions between 2008 and 2010. It found that there were over 4 million visits, and it costs almost $3 billion. It's a large problem. So what do? We realize that there's an access problem that's mainly hitting the low income, uninsured, or those who are uninsured or on Medicaid. We know that more people are going to be getting coverage for adults, and for adults, when it comes to dental coverage, it's largely going to be public coverage. We've got that trend going on. Dentists want to serve more underserved people, but need to do so in a way where they can keep their doors open, and in a way that financially makes sense to them. So one solution to the access problem we find are mid-level dental providers. And mid-level dental provider is a provider that plays a similar role in dentistry to what a nurse practitioner or a physician's assistant plays in the medical world. They offer preventive and routine restorative care under the supervision of a dentist, always under the supervision of a dentist. There are several different models. They each have different education and supervision requirements and scopes of practice. And right now, there are 3 states where dental therapists can practice: Minnesota, Alaska on Indian country, and Maine was the 2nd state in the lower 48 to approve dental therapists. Why employ mid-level dental therapists? They're being used to address a number of problems. They cost less to train, and because of this, both private and public practices are hiring them as a lower cost way to meet patients' needs for care. And we're finding that, that having them work in practices also frees up time for dentists to perform more advanced and costly procedures. So let me tell you about the latest research on mid-level dental providers. The findings are fairly encouraging in terms of increasing access and helping dentists generate income. This year, the Pew Charitable Trust released case studies on how mid-level providers are operating in private practices and public clinics, and I'd like to tell you about some of the findings, especially the economic findings. We went to a solo private practice in a rural town in Minnesota, Main Street Dental Care. They had been using a dental therapist for a year, and here's what we found after a year of the dentist working with a dental therapist. His patient volume increased, the number of visits increased, his Medicaid patient volume really increased. It increased by over 50%. To over 500. And the dentist owner was able to spend more time doing advanced procedures. So at the end of the day, after a year of working with a dental therapist, his Medicaid patient load was at 40% of his entire patient population, and he was able to generate an additional $23,000 in income. Now in Minnesota, this is notable because in Minnesota, the Medicaid payment rate is 41 cents, or 41% of what Main Street charges, of what their customary charges are. Let's just take a closer look at how the procedure mix changed for the dentist, Dr. Powers, who owns Main Street. You'll see that surgical extractions went up more than 20%, root canals went up 40%, implant procedures more than 40%. So he was basically able to do these more complex procedures because the dental therapist was handling a lot of his fillings work.
What we've seen is that dentists who employ dental therapists, and dental therapists are authorized in 3 states, are able to serve more patients on Medicaid while also being able to generate a profit.
If people have questions like more information about some of these issues, what should they do?
I would recommend that they go to the webs, the National Dental Association web, as well as they can get in touch with Mr. Johns. He has, and they would see the numbers and everything there, and they can just call.